Yeah, I'd like to welcome everybody who's joining us for today's presentation. This is Michael Saltzman from Blue Sky Bio. This is our second presentation in the 2021 webinar series. This year, we've tried something new by scheduling the webinars on Sunday mornings. So I'd like to thank everybody for clearing out your Sunday mornings. I'm sure you could be doing many other things on your Sunday, and instead you choose to attend the presentation and learn and get the CE credits. So thank you very much, and we'll see how it goes for future presentations in future years as well. We have the schedule of upcoming presentations on our website, blueskyplan.com, webinars 2021. We have a fantastic lineup of speakers and topics for the next few months. Pretty much every Sunday morning coming up for the next few months, there are webinar presentations. So check out the schedule. Register, they're all free of charge, and they're all 1 CE credit. As usual, if you have any questions during the presentation, please enter them into the QA box, and we'll see how many of those questions we could get Dr. Ferguson to answer. And we'll be sending the CE credits usually within a week or two after the presentation. For today's presentation, we have the honor of hearing from Dr. Rick Ferguson, the founder of Implant Educators. So if you like the presentation, which I'm sure you will, check out the website. They have courses from 1-day courses to 7-month courses on pretty much every topic out there. Dr. Ferguson's been educating for 20 years on a tremendously wide, different range of topics, lecturing in most cities throughout the United States and many other cities throughout the world. He'll be speaking on the topic of, is the lateral approach sinus graft dead? Current techniques for predictable guided crestal sinus grafting of most cases. Rick?
Well, thank you, Michael, for that fantastic introduction. I will say it is actually my honor to present today. I have been a big fan of Blue Sky for probably over 6 or 7 years now. We've been using the software and your products in our practice and in our courses, and I'm excited to be a part of this webinar series. So thank you for inviting me back, and I hope to do a good job today with this presentation. So the topic at hand is basically the sinus lift, and what current techniques do we have that will allow us to do sinus grafting with a more minimally invasive approach.
Rick, you could go ahead and share your screen.
Yep, thank you for that. So you should be able to see my slides now.
Yep.
Yep, so before I get started, a little bit about us, who we are. We are Implant Educators Academy. As Michael said, we run a 6-weekend live surgery course. We used to be 8 weekends, and we've whittled it down through the use of technology, especially to be able to do things more predictably now, into a 6-weekend live surgery continuum where we can bring any US licensed dentist to the state of Florida, and they can place implants, do bone grafts, including sinus lifts, etc. And in more recent years, going with the trends in implant dentistry, we've been doing a lot of all-on-X immediate load cases in our continuum. And on a more personal level, my wife, Dr. Catherine Ferguson, who is a co-founder of Implant Educators Academy, and I have a small private practice in a town called Davie, which is near Fort Lauderdale, where we have the technology that we need, the physical equipment that we need to take advantage of the Blue Sky Plan software and equipment. So in our office, we do 3D printing. We have a number of 3D printers, and we are doing 3D printing every single day and at night also. It's sort of taken over our practice in a lot of ways. And I want you to absolutely know that the future is now. This is not something that is difficult to get into. It's not something that is very costly to get into, but the impact that it can have on your practice is tremendous, especially now with the ability to do all the different modules in Blue Sky, everything from surgical guides to restorative, to creating models, to doing digital dentures and orthodontics as well, which we now teach in all of our digital courses.
Rick, sorry to interrupt. There's a rumor going around that today's your birthday.
Yesterday was my birthday. Thank you.
Very good. Happy birthday.
Thank
24, 25?
Not a little bit more. Keep going. We
Well,
don't have
happy
time to count,
birthday.
count through all the numbers today. But thank you, Michael, and thank you for all the wishes from all the people on Facebook, etc.
You should have many more, happy and healthy.
I hope so, and I hope everybody does as well. A disclaimer before I get started is that this presentation is not a replacement for proper in-person training and is only designed to supplement previous training on the diagnosis, planning, execution, and management of complications related to maxillary sinus grafting. The sinus graft is something that we have been doing for over 20 years in our clinical practice. And there are some great textbooks out there, some great training that you can get. This is one of my favorite textbooks, sort of a basic text on how to get into sinus grafting by Ole Jensen, with contributors from all of the big names in sinus grafting. And I want you to pay a special attention to this page 64 of this book, where it gives you sort of a flow chart where you can determine which techniques to use based on the amount of alveolar bone height left, etc. So it's sort of a simplified chart, and I will reference back to it several times in the webinar today. But it's a great text for anybody planning to do sinus grafts or already doing sinus graft. Great reference text. So the goal of sinus elevation, of course, is to create vital bone in the posterior maxilla, placement of implants into that bone, and survival of these implants under occlusal load. The sinus itself is a structure that can be found above the teeth that we need to be concerned about, certainly, if we're placing implants. And I'm not going to spend a lot of time going through the basics here. I'm just going to sort of run through this very quickly. But of prime importance is the ostium. We want to make sure that we have a patent ostium, whichever type of technique that we want to do, whether it's a crestal approach or a lateral window approach, because that is the drainage point of the sinus. And there's an active and a passive drainage that goes on. So it's of prime importance that you always check the patency of the ostium before we undergo any type of sinus procedure. And that means that you have to get a proper CBCT image that shows the ostium, whether it's patent or not. The ostium itself ranges in size, and the structure, the length of the structure that then goes into the nasal cavity is called the infundibulum. There's a lot of good research out there, a lot of good texts on these anatomy texts that you should study if you're going to be doing sinus grafts. Also of prime importance is the branch, intraosseous branch of the PSA that runs in the lateral wall, because oftentimes if you do a lateral window sinus graft, you'll be encroaching on that structure, and that could present you with some bleeding that you may have to manage. So again, it's something that, yes, we can manage it, but you know, I'm the type of person, I don't like surprises. So I always like to take a good CBCT and check what I'm getting into. And that's sort of what you'll be seeing in the lateral wall of the sinus. And if you can avoid it, of course, you want to do that. And preoperative evaluation, determination of active disease processes such as acute or chronic sinusitis, polyps, tumors, cysts, retained root tips, etc. All these issues should be corrected prior to any sinus lift procedure. And again, everything that we talk about with disease processes applies to not just the crestal approach, but the lateral approach as well. We need to understand the difference between acute and chronic sinusitis and know when to have a medical evaluation. What you're seeing here is from a textbook, an ENT textbook, sort of showing you the complexity of a flow chart for treating sinusitis. So again, it's something that you want to make sure and have a good evaluation. And if you do need to get medical clearance for your patient, do so, because as you can see, the treatment for sinusitis can be complex, okay? The Schneiderian membrane, which is the goal of the sinus lift, is to lift the Schneiderian membrane and place bone underneath it. And you can see it can be very, very thin, anywhere from 0.13 typically to 0.5 millimeters thick. Typically, I recommend to our students that we train to do sinus grafts, that if it's 3 to 4 millimeters, depending on their comfort level, refer the patient to an ENT for preoperative evaluation. The cells themselves have hairs that actively push mucus up to the ostium and out into the nasal cavity. And what's important to understand is that this is an active process that occurs during the daytime and the nighttime. And whenever there's any surgical insult to any part of the sinus membrane, this process will slow down or stop. So even doing a crestal approach, this process will stop, and what you'll get now is a collection of fluid that is not being actively pushed out of the sinus. And now you're relying on the patency of the ostium for a passive flow out of the sinus. And if the ostium is not patent, that can lead to infection, and because what you now have is a stagnant system and can lead to sepsis. So it's important to understand what you're getting into, and it's also important to understand the pathology of the sinus and make sure you're evaluating it properly. Here you see some cloudiness in the sinus. You see what looks like some septums. Those can certainly complicate how you approach a sinus lift. Now, with the lateral window approach, you can graft large areas. We can have direct visualization of the sinus membrane, which makes it great to be able to lift it properly. The access is remote to the implant osteotomy, leading to stronger bone typically around the crest of the implant. And that's why the lateral approach was favored for many, many decades. The surgical approach itself to do a lateral window is you're going to take a round diamond burr or a piezotome, create an oval shaped window with cool saline irrigation. And here, my favorite instrument to do this with is a piezotome because it's very gentle and you can actually go right up to the Schneiderian membrane and not damage it. The piezotome only cuts mineralized tissue. So this has changed the way we do sinus lifts over the decades. And we've been using a piezotome for about 20 years now, actually, to do our lateral window approaches. It's important to understand that when you lift the membrane itself, you want to lift all the way to the medial wall of the sinus. This is well known in the literature that the source of new bone growth is going to be from the bony walls of the sinus. Now, lucky for us, there are lots of bony walls. There's a medial wall, the anterior wall, the posterior wall, the floor, and some of what's going to be remaining of the lateral wall, which makes the sinus a great place to graft, very predictable to graft. The blood supply there is very good. So we have good source of osteoprogenitor cells from all the different walls, but we have to make sure that we lift the membrane away from those walls if we want to grow large amounts of bone. So you can see here we've entered into the window, we've created a window, and we're now peeling back the thin Schneiderian membrane. This is a technique sensitive procedure. There's no doubt about that, but the learning curve on it is actually very steep. Typically over the years when I've trained dentists how to do this procedure, they can learn it and feel very comfortable after about 3 procedures, 3 times doing this. So it is something that you can learn. It's a skill you can develop. And I've trained hundreds of dentists how to do this chairside in their practices, at our courses, etc. But it is something that you do have to spend some time. And typically for me, it takes me about 45 minutes to do a lateral window sinus graft, bilateral about an hour, hour and a half. So it's something that is, again, predictable, something you can do in your private practice. However, there are complications and you'll need to understand how to deal with complications. The incidence of perforations of the membrane vary, from 30% to down to 77%, depending on your skill level, depending on the amount of time I think that you take to do these procedures. one of the things I recommend when you're doing a lateral window sinus graft is you have periods when you're going to just slow down and take a deep breath. And that's especially when you're lifting the membrane itself. That's something you can't rush. That's something it's going to take some time. There's some finesse that you have to have, especially if you get in there and you realize the membrane is thin. And yes, you are going to have perforations, but perforations are fairly easy to deal with. We have techniques of grafting using collagen membranes and so on. So it's rare that we'll actually abandon a procedure if we have perforations. As long as the membrane isn't completely shredded, we will typically be able to graft it anyways. And again, these are things that I think you need to attend a live surgery course or a cadaver course to learn how to do. As far as the materials that we're using in the sinus, it's well known that we can get very good results with xenografts and other materials. And you don't have to have autogenous bone. Autogenous bone, when folks first started doing sinus grafts, was considered the gold standard. And we quickly learned that it's actually better to use materials other than autogenous or even allografts, or maybe do a mixture. Typically today we're using a mixture of a xenograft and an allograft. But you don't need a lot of autogenous bone in order to do the sinus graft. And that, again, makes it easier as far as the process of acquiring the bone grafts. And then the other thing we are using quite a bit with our sinus grafts and with all of our surgeries is growth factors. We're using PRF typically, and that brings these different growth factors with it. The most important, I think, is what's called vascular endothelial growth factor, which really helps greatly with soft tissue growth and soft tissue healing, as you'll see how we use it. The piezo surgery was a game changer when it came out for the lateral windows, because it helped us reduce the number of perforations. And in this one study out of NYU, you see they were able to reduce perforations from 30% down to 77%. Perforations are, again, something you're going to incur, and you do need to know how to deal with them. But if you can certainly reduce them, that makes the process go a lot easier for the surgery, okay? There are complications that can occur. And again, I'm not going to go into every single complication here. I expect that if you are going to do sinus grafts, you take, you get proper training. But just quickly, infected grafts are something that we've had to deal with over the years. We only had a handful of infected grafts that we had to go in and remove the graft material. There are techniques that we use now. We have specific antibiotic and steroid protocols that have pretty much eliminated our incidence of infections and so on. And we teach those in our implant continuum. I don't want to get into all of that right now, because I think there needs to be context when you start teaching about medications for these types of things, especially when you're dealing with steroids and prophylactic antibiotics. But here's a patient that we had done a sinus graft. This was actually done at our implant continuum, a lateral window approach. And the very next day, this is what the patient looked like. So some of you might recognize what's going on here. Some of you may not. I would recommend that if you don't, again, get proper training. But we were able to just treat the patient with medications, and literally overnight, the situation resolved itself. So an understanding of what the different sequelae can be is important to know how to deal with it. But again, we have specific antibiotic and steroid protocols, which we teach to prevent this type of scenario from even happening in the first place. As you can see, this was an older case, but today we rarely have situations like that happen. So here's your typical patient that presents with a terminal dentition. This is Angela. She's 54 years old. And in her situation, she had no bone posterior to the molars. For placement of implants, she had a lot of decay, a lot of teeth that needed to be removed. She, presented to us for full arch or full mouth rehabilitation. And you can see from her CBCT image here that she really didn't have a lot of bone even where she had teeth, which is somewhat unusual. The bone was extremely thin. And because of that, we decided to edentulate her and go ahead and do bone grafts. You could see she has periapical abscesses. It might have even been difficult for us to do an all-on-X immediate load on her. So our choice here was to edentulate her and do bilateral sinus grafts with lateral augmentation in the premaxilla area as well. And this is what led to our that treatment plan. You can see here, this is an older software we were using at the time to plan the case, and you can see that she really didn't have adequate bone anywhere for us to place implants without bone grafting. So we did quite a bit of bone grafting on her, but focusing on the sinus aspect of it, we did bilateral sinus grafts, 8.5 cc's of bone total, 6 cc's of mineralized allograft, and 2.5 cc of a synthetic material called Oristruct, which we were using at the time, similar to a xenograft type material. So a mixture of allograft and xenograft. And you can see how we were able to certainly increase the amount of available bone to place implants. So this is what it looked like 2-week post bilateral sinus graft. You can see there's minimal trauma here if you know how to manage the case properly, but still not as certainly more traumatic than doing a crestal approach. But in a situation like this, I would probably still go with a lateral window approach. Here's after the implants were placed. These were not done guided. Unfortunately, at the time, we didn't have great software like Blue Sky and techniques to do guided all-on-X type cases. So these were placed freehand. And you can see this was the patient's temporary, which was an acrylic hybrid that we created as a temporary appliance to work out the aesthetics and so on. But this was her smile with that hybrid in place. And eventually we converted that to a fixed zirconia hybrid. Now you can see here, we actually ended up changing, you might have noticed we changed one of the multi-unit angles here, so we'd have a better spread around the arch of the implants. But overall, I think this case turned out pretty good. The patient was very happy with the results, so that's what's important. So that's a situation where, a typical situation for us where we're using a lateral window approach. Now let's get really to the topic of today, which is a crestal approach. The advantages, of course, of the crestal approach are reduced trauma, less surgical time. Typically, we can place the implant at the time of the grafting, and that leads to overall a faster treatment time. And again, it's important, though, to understand what we're achieving with a crestal approach. We're typically not getting the scenario on the right-hand side here in most cases. And that's going to help you determine, looking at the anatomy of the existing bone, which approach you'll want to use. So what you see here is we're not lifting up to the medial wall. That means we're really getting bone growth from the lateral wall and then mostly from the floor. But so if we're putting an implant in here simultaneously, that's going to limit the amount of bone growth we can get from the floor. So let's start off with one of my older cases. This is a case where a patient presented for full arch rehabilitation as well. His main complaint was that he was missing teeth in the lower right quadrant. And certainly we could put implants there. But during our discussion, he also mentioned that he had a bridge on the upper left. And could we remove that bridge and put single teeth there instead? And of course, the answer for us is always yes. So we took a periapical and estimated that he had about 8.5 millimeters of bone between the premolar here and the molar in this molar site, first molar site. And at the time we were really putting in long implants. We were planning to place a 10 millimeter implant. So our goal here was to do some sort of sinus elevation and place a 10 millimeter implant. And this was the result. We placed a 5.8 or 6.0 diameter, I believe. This was a Zimmer implant, which we were using back then. And we were able to tent up through the osteotomy and do a nice sinus bump there using allograft. So what was the sequela after this graft was done? You can see months later, we went back and did the final impressions. This was at the time of implant placement. If you remember with the Zimmer system, the driver looked like the impression coping. So this was when the day we put the implant in. And months later, we went back and did the final impressions. You can see we had lost some of that bone. That's typical with a fast resorbing graft material, such as autogenous bone or allograft. So this was a sequela, and you can see a couple of years later what it looked like after it was restored. However, we did get, most of the graft is gone, but we did get some bone growth up the implant, which was interesting. And we could still call this a success, even though we don't have bone at the apex. Now, what could we do today to keep that bone from resorbing back is to use a slow resorbing graft material such as xenograft. So that's what we're recommending today. And what that does, it allows a slower bone turnover, which allows more natural bone, more osteoprogenitor cells of the patient's own bone to grow in. And even if that does not happen, it will we'll still have the particulate xenograft, which will get encapsulated in the patient's own bone as it grows in. So basically it becomes a race between resorption of the graft, which occurs very quickly if you don't use a denser material like xenograft, because the Schneiderian membrane itself will cause a resorption of the graft material. So my go-to today is a mixture of, for a lateral window approach especially, is a mixture of allograft and xenograft. However, for the crestal approach, I'm using 100% xenograft, small particle. So this was the final result for this particular patient. There's where he started, and that's where he ended up with his full arch rehabilitation. We did some whitening. We did get the implants in on the lower right. And some of you might notice that he's actually has a congenitally missing lateral as well that we sort of masked with the prosthetics. Here's another technique. We did use a Summers technique on that patient, but here's another patient where we were using the Summers technique as well. And what I want to point out here is that the Summers technique was one of the first techniques for doing crestal approach. And what you would do is you'd use osteotomes with a mallet. So this is Larry, and on the previous case, that's what we did as well. We used osteotomes with a mallet, and we would tap up the bone, drill a small hole, and tap up the bone using osteotomes. And the problem with this, it was somewhat traumatic for the patients. So, however, we got good results with it. As you can see here for Larry, we did an immediate extraction of the premolar and placed 2 implants one into the grafted premolar site, one where we had enough native bone, and then the last one on the molar site where we did a Summers osteotome technique to push up the Schneiderian membrane. And again, we had to use a mallet. Patients really don't like that. But you can see at 9 years out, we have a good success with this technique. So, this was our early attempts at crestal approach sinus graft, worked well, but somewhat traumatic for the patient and in some ways somewhat unpredictable. And that brings us to the Blue Sky hammerless crestal sinus lift technique. So this technique is something that we adopted several years back. I looked at the technology behind it using these burrs that are called safety stop burrs that prevent the bone from going into the Schneiderian membrane. It pushes, the drills push the bone ahead of it. So we adopted this technique. And with this technique, you can go to the Blue Sky website and see how the technique works. I'm not going to run through the entire video
explains
here.
How to use the Blue Sky, but not require uncomfortable hammering of the sinus floor or
Now you notice what they started out saying there. It does not require uncomfortable hammering of the sinus floor, which was a big for us. The patients really don't enjoy that. Most of our patients are awake. We don't do IV sedation in our practice, as most people here probably don't either. But this was very uncomfortable for the patients. And we were looking for techniques that were less traumatic. So I'm not going to play the entire video here, except to say that there's a very, it's a sequential approach. It's very predictable. It works extremely well in most cases, and we had very good success with it. I was actually quite impressed by the system, to the point where we started teaching it in our courses. So you can go to Blue Sky site and watch that video. You know, so I started recommending this kit to our students after my experience with it. And I can show you lots of cases where we use these techniques, but I think it's also good to show cases where our students actually adopted these techniques and used it for their own cases. This is one of my past students, Dr. Darlene Hart, who used this technique. This is her first case doing this technique with this kit. And you can see the result that she was able to get here. Just a nice, you know, amount of graft material. Actually went up the medial wall as well as the lateral wall, mesial and distal as well. So we know we got a total of 12 and a half millimeters of height here. So we could easily place a 10 or 11 millimeter implant. And if you look down into the sinus, you can see that nice bump, you know, that tenting and the graft material in there as well. This was 100% xenograft, and this is a kind of success that you can get. So this is in essence an ideal case scenario, because the fact that we're using xenograft, the fact that we went and got a lift up the medial and lateral walls, is going to give us a nice source of osteoprogenitor cells. And you know, this, although this was her first time using this kit, she was trained by us in lateral augmentation and other techniques such as a Summers technique prior. So it's easy for somebody who's already doing those techniques to adopt this type of technology. Here's another case. This is another one of my students, Dr. Zineb Medouini. She's a prosthodontist in the Tampa area, North Tampa area. You know, I actually helped her out with this case and walked her through the use of this kit. So we started off with 5.35 millimeters height of bone. And you can see again the nice lift that she was able to achieve using this kit. And if we again look down into the sinus, we can see this nice bump as well. And our osteotomy is prepared at the same time for our implant. And there was the implant placed. So again, a very predictable technique. And then Blue Sky went one step further and created, using the same types of drills, the guided sinus lift kit. And for me, who's a big aficionado of doing, big proponent of doing guided surgery, this was really a huge game changer. So with this kit, it even makes what the previous kit gave us more predictable, because the previous kit was not a guided system per se. There are ways you could get it to work with the Blue Sky software, which we did to make it guided, but this just made all the difference, because the drills here had drill stops on them that worked with a surgical guide. So when this came out, I immediately adopted it to our practice and to our courses as well. We gave it a try, and I was really impressed by the design of the kit and the fact that by using a surgical guide with it, we could make it more predictable and make it easier for folks to incorporate into their practices. So again, you can go to the Blue Sky website, and there's a great video where Corey Glenn walks you through the entire system.
Blue Sky Bio fully guided crestal sinus kit allows you
and
to
talks
safely
about
reach the sinus floor
how to use it with a surgical guide.
By 10 millimeter implant with only 6 millimeters native bone to the sinus floor. The keyless design of these drills matches exactly to the Blue Sky Bio fully guided surgical kit. When using these sinus drills, also have depth
So
stops. Drilling should proceed since the sinus
you can
floor
see
is
here
not yet patent.
a couple of things he
Now
said.
take the 7 millimeter long drill to full depth without running it. Note that this time the drill stops.
It's designed to work with a surgical guide. And one of the things that Corey says in the video is that it's designed to work seamlessly with the Blue Sky fully guided keyless kit, which is absolutely true. If you're using that kit, the settings are already built into the software. There's really nothing else you need to do. It's a very straightforward system. For those of you who are not using the Blue Sky fully guided keyless kit, what you'd want to do is use a custom kit function in Blue Sky, which is great. Blue Sky is really a nice, completely open software, and you can adopt it to use with any surgical kit. And this is something we teach in our guided surgery courses. But if you change the offset to 8.5 and plan the implant out exactly like you would normally, then you can use it with most systems. You do have to make sure that you use a sleeve, and you can get the sleeves from Blue Sky. We happen to use the sleeves. We use a BioHorizons kit, so we use the sleeves from BioHorizons, and the green sleeve from BioHorizons actually works really well with this kit as well. But if you're not using that particular system, I'd recommend you get the sleeves from Blue Sky, and they can help you out as far as sourcing the sleeves. But what you want to do is change the offset manually to 8.5, and that will give you the correct depth so that the distance from the guide tube here to the top of the implant is going to be 8.5. And you can see that leaves you well short of the sinus. And then as you walk through the sequence of drills, it gets you right to the floor of the sinus using the technique that Corey talks about in the video. So I absolutely recommend you go ahead and watch that video before you use this system. So here is a case that I did with the kit. Here we started off with 5.67 millimeters of existing bone. This is Armin, 66 years old patient. I had done an implant over here for him, a couple other implants in the lower jaw, and he lost tooth number 14. So we decided to use this kit to do the crestal approach sinus. And we're using it here flapless as well. We had done a socket graft, but even with the socket graft, because the bone was invaginated down between the roots of his teeth, we were not able to get enough bone even from a socket graft to place an implant of the proper length, in which my preference would be to put a 10 millimeter implant in there. So we designed the case in the Blue Sky software, printed the guide on our Formlabs printer, and used it with this is being used with the BioHorizons kit. And again, make sure we change the offset to 8.5. And what you see here is we're collecting bone as we go. So we will collect that bone and use PRF. These are not Armin's case, but the idea here is to use something ahead of the drills and ahead of the osteotomes that you're going to be using to push up the Schneiderian membrane, something that's soft. Now, my preference is to use PRF because it does have the growth factors in it. And if you do get a small perforation in the membrane, which is going to happen, I'll show you a slide on that later, but it will occlude that perforation. Now, Corey in his video talks about using a collagen plug. And if you don't have PRF, that would be my next preference. If you don't have that, then maybe use a piece of collagen membrane. But my preference, and I would recommend everybody get into use of PRF. It's just a great technology. It's a great addition to your implant practice. So we're using PRF first before we start putting in the different graft materials. So once we have the PRF in, we use this carrier that comes in the kit to carry the bone to place, and then use a set of pluggers to push the graft. This is now a mixture of the autogenous bone that we got off the drills, along with the xenograft. That is my preference, a small particle xenograft. It's important to use a small particle so that it doesn't perforate through the Schneiderian membrane as large particles may tend to. And again, you go through the sequence, you put in, every time you put in a scoop of bone, you're going to be lifting it. You're looking at about, one scoop for about 1 millimeter. So think of it that way. You're going to be lifting 1 millimeter. Of course, if the bone goes laterally, that's great as well. So you probably need a little bit extra bone. So we are taking a periapical x-ray during the procedure to see how much bone we have lifted or how much bone we have grafted. And you can see now we've got this nice tenting of the graft here. When you see that, that's really something you're going to be pleased with, because that tells you that the bone graft is encapsulated and you probably don't have a perforation. Or if you do have a perforation, we have our PRF membrane up there to help occlude that. And with the growth factors in the PRF material, that helps that heal very quickly. What's going to happen as you traumatize this membrane is that it is going to swell up. And that's actually a good thing, because the natural swelling of that membrane during the inflammatory phase of wound healing will actually help seal up any perforations as well. Okay. And here's the implant placed with a cover screw. We had enough existing bone that we could get good initial stability of the implant, but still we don't want to load these cases immediately. So if you are putting, this is a healing collar, your choice would be to put a cover screw or healing collar. If you are putting a healing collar, make sure it's just a very short one and that the patient knows not to load that area. And here's the follow-up. That's actually a 9mm implant that we placed. You can see we've got a nice tent of bone there. We were okay placing a 9 here because that's a wide diameter, 5.8 diameter implant. Here's another case, a more recent case that I did. This is Margaret, and we were showing here how, we were able to do two implant site using the same technique. We planned it out. We had started with 6.24 millimeters of bone, and this is our surgical guide that we created. This one I printed on the Unis/2 printer. I have a ton of different printers which we use interchangeably. So if you want to learn about 3D printing, we certainly have courses on that as well. And we're not tied to any one particular 3D printer. There are lots of good low-cost printers out there that you can use for these techniques. So we went through the procedure just as we did before on Armin's case, except we're working on 2 sites. And you can see this is our periapical x-ray that we took during the procedure to sort of visualize what was going on, how much bone graft we had placed. And you can see we're actually developing our osteotomies as well. Now, the guided surgery system uses a 3.6 diameter drill. So it's important to understand that if you're going to be using the guided surgery kit to do your crestal approach, you will need to be putting in an implant that's typically greater than 3.6 millimeters in diameter. So typically, though, where you're using this system is in the posterior maxilla, and that's what you'd be doing anyway. So I think it's a perfect fit for this particular procedure. And here we are with our implants placed. I believe these were 4.7 diameter implants. And you can see the 2 here in the distal because they were done guided. Beautiful amount of bone on both sides. We have bone up over the sinus. And I can walk you through a visualization here through the different implant sites. We did get a little bit of lift here on the medial wall as well. But again, we have allograft and xenograft, 100% xenograft that will keep that Schneiderian membrane from resorbing down, and we'll be able to get some nice bone growth. Interestingly, if you look at the implant here, the most mesial implant, that's an implant I had placed 20 years earlier. And obviously it was not done guided, as you can see by the thin amount of bone we had out there in the facial, but it's still going strong, and there's no reason to remove it. There's no problem with it, but it just shows you the advantage today of doing guided surgery, how much more precise we can be from doing freehand surgery. And I'll show one more case using the guided surgery system here. This is BB, 44 years old. And this case was actually done just on Friday. This was done by one of my students, Dr. Carlos Guaranero in Orlando. And this again was his first time using this kit. He actually trained with us. So again, he's familiar with doing lateral sinus augmentation and crestal approach using Summers techniques. But this was his first case doing the guided surgery with the guided crestal approach with the Blue Sky kit. And he did 2 sites here you started off with 4.76 millimeters of height of bone. And I did help him a little bit to design the guide. Just basically, he knows how to do guides, but as far as the offset, again, I walked him through how to input that in his software. And here's the post-op. You can see he got a nice bump here of bone around the implant. This is what it looks like looking down into the sinus. And of course, the mesial site just got a little bit there, but he wasn't really planning to bump that up either. He had enough native bone there. So again, another successful case. We can look through the slices here, go through the cross-sectional views and go around the implant and see that we've got a good amount of bone ahead of the implant. And we expect, again, because he used a xenograft here, that it would work well. Now, he did tell me that he didn't have a collagen plug and he doesn't use PRF. So I told him to use a collagen membrane, and that's what he put there, just a small piece of collagen membrane ahead of the bone graft. The way the kit is designed, the drills and the pluggers never actually go past the sinus floor. And again, watch Corey's video on that. He does a nice job walking through the entire system and explaining how it works. Very impressive technique. So to answer the question, is the lateral window sinus graft dead? And the answer is no, certainly not. But we do have the ability to do most of our sinus grafts now using crestal approaches. But we have to keep in mind that we're working blind and we are going to get perforations. If you look at the study from 2012, Jaime Lozada's group out of Loma Linda, published in the Journal of Oral Implantology, they did cadaver studies, and this was done with several dentists as well as Christopher Church, who's an ENT. And what they did was they did endoscopy and looked at using three different methods of doing crestal approach sinus grafts and what the results were looking down into the sinus through endoscopy. And it's interesting that they found that perforations were recorded in 40% of the elevations. Now, they did not use the guided surgery system that I'm recommending here, but they use other similar systems. And the point is that there was quite a large number of perforations. 40% is not insignificant. 36% of specimens had a small perforation. And also, endoscopy indicated a perforation of 4% correlated with surgical instrumentation alone, 12% linked to the graft insertion procedure, and 24% associated with the implant placement. What that means is as the amount of tension on the membrane increased, so did the number of perforations. And also of significant importance in the study was that the practitioner was unaware of these perforations, okay? Other things such as the graft material used, the amount of level of hydration, the size and configuration of the bony particles, and so forth also may influence the outcomes. Equally important is the implant apex geometry, sharp or rounded apex, as it may play an important role when the implant placement is in close vicinity to the elevated sinus. Now, I think that can be alleviated by making sure that we have enough bone graft ahead of the implant rather than having the apex of the implant pushing against the Schneider membrane. So it's important to get a good volume of bone up there before you put your implant in. And that's what we were checking on that periapical x-ray. All right. So how can we explain what's going on when we do this crestal approach? And, you know, I like to keep things sort of simple in my explanations and my own understanding. So the reason I think we're getting more pressure as you go up and you start putting bone graft materials in is because of the angles we're dealing with and the tension on that membrane. Now, if you look at a large flat area and you're using these crestal approaches, what you're going to end up with is an obtuse angle as you start pushing the membrane upwards. In both situations where you have a sloping wall or where you have a somewhat flat floor, what you're going to have is when you first start pushing, you have obtuse angles, and the tension is going to be fairly equal on both sides. Okay, so this is at the beginning of the procedure. And again, this is using the Summers technique where you're pushing with osteotomes. But a similar thing happens when you're using the bone to push ahead of the instrument also, or PRF to push ahead of the instrument. So what you're seeing here now is you start lifting, the tension now becomes at an acute angle to a sloped floor versus remaining as an obtuse angle on a flat surface or a flat floor. So if anybody who has ever peeled some tape off a roll of tape or tried to remove a label knows that when you pull at an acute angle on that roll of tape, it's much easier. You don't have to apply as much force, right? Versus trying to peel the tape at an obtuse angle. You do have to exert a lot of force. So what does this tell us? What this tells us is that the force at this acute angle as we start to lift is much less on the Schneiderian membrane at an acute angle here versus an obtuse angle on a flat floor. And we can use this knowledge when trying to decide which approach to use for our sinus grafts. Again, peeling something away, if the tape here is our membrane, going at an acute angle means that there's less tension on the Schneiderian membrane than going at an obtuse angle and trying to pull laterally basically against that membrane and peel it away from the underlying bone. So if we look at a case, this case was done by our students in our course at the University of Florida Clinic. This is Stephen, and we're planning to do 2 implants for him and a lateral window sinus lift. So we actually had three doctors working on this case. And if we look at the right side here, we see that the floor is fairly flat. So in a situation like this, unless we were planning to just put 1 implant on the slope part of the sinus here, of the anatomy, we'd probably be okay using a crestal approach, but our plan was to put 2 implants in. And you can see back here, it's much, much flatter. That's a situation where I would recommend a lateral window approach, because we're going to, if we try to put our crestal approach drills back here and start to lift, what we're going to have is much greater tension on both sides trying to lift that Schneiderian membrane. So this is a situation where I would definitely choose to do a crestal approach unless we were putting just 1 implant along the sloped area here. So this is, as the case went through, we were doing a guided surgery for the 2 implants. Dr. AV placed an implant at the number 12 position, and Dr. SS placed an implant at the number 6 position. And then Dr. KP, who was tasked that day to do the sinus lift, we opened the window and placed the graft material, lifted the membrane. You can see we did get a perforation there, right here, and which we had to occlude with some collagen membrane, but that did not stop us from finishing the procedure. And he was able to put the graft in. We did use PRF, and this was the result for that patient. Quite a bit of bone back there, so we can go back later at a later date and put in 2 implants. Dr. Brandon Marks asked, is there a minimum height of bone to use a crestal approach? Also, is there a minimum height or percentage length of implant you would use immediately for immediate implant placement? And I will address that question in a minute. I have a slide on that. But let's look at another case. Is the lateral window approach dead? And again, the answer is, for me, no. But again, the vast majority of cases we can probably do with a crestal approach. So this is a patient that I inherited. This is Ursula. She is 80 years old. She was treated by an oral surgeon and a prosthodontist. The oral surgeon placed 4 implants in her premaxilla, and that was the restoration they made for her. You can see how flat her ridge is. This thing kept moving around. She was not very happy with it. You can see the oral surgeon placed the implants all straight, placed 2 of them into the nasal cavity, which is not unusual. It's a technique we employ sometimes ourselves. So the implants were actually quite well done. But for some reason, this oral surgeon does not like to do sinus grafts. So what are the options that they could have employed here? He could have done bilateral sinus graft and put implants in. He could have angled these 2 implants a little bit better. I don't know if there was enough bone to do that. And then did an all-on-4 type of case. But either way, I am now tasked with rehabilitating this patient. And you can see that our current techniques of avoiding sinus grafting involve all on X, using Malo's technique of tilted implants, and we employ that. I actually teach a course on that as well. But there are situations where that's not even possible. So folks have gone over to doing things like zygomas. Now, the zygoma to me is somewhat of a cop-out. Yes, there are indications for it. I would think that those would be severely resorbed maxillas where you just don't have any other choice. But in the vast majority of cases, we have been able to rehabilitate our patients using sinus grafts, lateral window or crestal approach. And in a case like on Ursula's, that was the approach I took. What we decided to do is not abandon the 4 implants that were already in place, but add to them. So we did bilateral sinus grafts, lateral window approach, very straightforward. It took me about an hour to do both sides because she had fairly flat anatomy in the sinus floor, easy access. We went in and lifted the membranes and put some graft up there. And then we waited about 4 to 6 months for the graft to take. We did have a perforation on the right-hand side, so it limited the amount of bone that we could grow there, but still it was enough. And then I wanted to be able to line up all the implants so that they would be straight with the 4 in the front. So I used a guided approach. We scanned her existing ball attachments on her 4 implants, scanned it with intraoral scanner, developed a surgical guide on top of that using the Blue Sky Plan software. I even created some windows so I could see that the guide would be seated onto the ball attachments. The guide actually snapped right onto the ball attachments, which made it very firm and gave us a great index for placing implants into these 2 sites where we had done our sinus grafts. So the implants were placed, they were allowed to integrate, and then we went back and uncovered them. And you can see we used straight multi-unit abutments, except on this 1 implant back here, I had to use an angled, I believe that was a 17-degree angle. Got everything nice and parallel, converted that to a temporary hybrid, which we did by scanning the patient models, created solid models, scanned them with our intraoral scanner, brought them into the Blue Sky Plan software with a wax rim, and then created a denture using the denture module, and went ahead and developed a temporary hybrid from that, which we printed on our frozen sonic printer. And this was it characterized, picked up, and then we use an Axcom pink composite to do the characterization. My assistants actually are very good at this. And then we put that in and made sure that the aesthetics, the function, speech, etc., was good. You can see the discrepancy between the existing premaxilla and where we had to bring her out to match up with her lower teeth. And once we got the patient happy with that, we actually again scanned that temporary. There were some adjustments that had to be made on the temporary, as there usually is. And we went ahead and scanned the temporary 360 degrees, remounted the case using that temporary, that printed temporary, and then had the laboratory design in, I believe, Exocad and mill a final zirconia hybrid. And that was the final result for this patient. So you can see what it looks like after the final x-ray. This is where we ended up. And if we look at the before and after, just a dramatic improvement for this particular patient. So that's, that's, I think, a good outcome, salvaging a case that, was sort of, in my opinion, left abandoned in many ways, because this lady certainly had the financial resources and the will to get the case done properly. All right. So in conclusion, there's less indication, I think, today for a lateral window approach, although there still are some indications. Choose cases with a sloping sinus wall or septum for a predictable crestal approach. Use a guided system for best success. Perforations will occur and most likely will go unnoticed. So my recommendation to help with that is to use small particle xenograft mixed with autogenous bone from the drills. I don't think you need to use allograft in these cases today with the crestal approach. With the lateral window approach, we're still using a mixture of xenograft and allograft. Add PRF to your protocol to help prevent and occlude perforations. Get proper training both crestal and lateral window approaches so that you can manage complications, because the complications can be similar with either crestal or lateral window approach. I don't think a crestal approach is necessarily a shortcut or carries less risk with it. And for large flat sinus floors or cases with less than 3 millimeters of existing crestal bone, I would certainly use a lateral window approach. Of course, cases also with septum and so on, you're going to have these nice slopes. So this is a lateral window approach we did many years ago in a case that had a septum. Today, I would just use a crestal approach in that. And of course, my favorite technique to do it today is the Blue Sky kit. And to answer the question about how much existing bone you should have, I would say 3 to 4 millimeters is good for a crestal approach today. I know in this particular chart, they talk about having 3 to 4 and using a lateral sinus augmentation approach. I think with the Summers technique, you definitely need to have 3 to 4 millimeters. But with this particular guided surgery kit, guided crestal approach kit from Blue Sky, I think you can get by with even 3 to 4 millimeters because it is so precise. And certainly having more than 5 helps, because you can then go ahead and do immediate placement of your implant. If you have 3 to 4 millimeters, depending on the design of the implant, if it doesn't have any very strong or very aggressive threads at the crestal portion, you might want to delay the implant placement if you only have 3 to 4 millimeters of existing bone. Anything less than 3 millimeters, I'm going for a lateral approach. Okay. So this, to finish, has been a game changer for our practice and for our courses, so much that we added it to our armamentarium and our techniques that we teach in our implant continuum. This is our 14th year that we're going into now with our implant continuum. And last year we added the guided crestal technique in a hands-on workshop, as well as in the clinic where we do our live surgeries. So it's really been a boon for our clinical practice. Even our past students have come back to learn how to use this particular kit, and I've helped them incorporate that kit into their practices. So I give kudos to Blue Sky for developing and releasing this guided kit, and also the previous kit, which was not a guided kit. But one thing about this particular kit is you can use it without a guide as well. So when people ask me, should they buy the previous kit or this kit, I'd like to tell them to use this kit, because you can use it for non-guided surgery as well. So the drills are the same, but we have both, so obviously it works out well for us. And if you have the resources and you're doing most of your cases freehand, I would say get the previous kit as well. but this one you can use for non-guided as well. It just has the advantage and that you can use it for guided. Okay. If anybody wants to learn more about 3D printing and all different aspects of 3D printing for our practices, we do have courses. Go to digitaleducators.com. We have a restorative course. We have a clear aligner course, which we're now teaching Blue Sky Ortho. And of course, the guided surgery course, the basic course. And then our newest edition is the All on X guides that we're teaching how to design the guides, including stackable guides, as well as the temporaries to do an immediate load, all on X type of a case. So you can do this all in your office yourself using fairly low cost 3D printing techniques. And we're proud that we're able to offer this course. We just started doing this last October, and it's been we've had a lot of good response from that. Now, all four of these courses are actually online, and the way it works is you register, you get the previous course video as well as all the practice files, and that prepares you for the live stream. The next one we're doing is the live stream of the All on X course on April 11th. So I want to thank Blue Sky for powering everything that we do in our clinical practice and in our courses as well. So I'll leave with one last thing, which is a recent article I published on the All on X technique using only CBCT data, not incorporating intraoral scanning. Although if you have an intraoral scanner, we teach you how to use that for the All on X type cases as well, but you can do it all with just CBCT data. And I published an article in December on that in the compendium. So with that, I would like to thank Blue Sky and Michael. I will turn it back over to you. And
Rick, if you have a few minutes and you could open the Q&A list and maybe just see some of the questions or field a few of those.
Sure.
If you have a few more minutes.
I did look over and I already answered one of the questions about the height of bone in that last slide. Minimum height, I typically like to use implants of 9 millimeters or more. If I'm doing a sinus lift, we will typically be putting 10.5 millimeter implants in, or somewhere around 10 or 11 millimeters. The advantage of the zygomatic implant is that you don't need to wait for grafting to heal. Absolutely. But I am not set up. I think with the zygomatic approach, you do need to do IV sedation to do that type of situation. Who knows? Maybe in the future, I'll adopt that technique as well. But I'm very comfortable doing what we're doing now. And I think for most clinicians, especially GPs, a lateral window sinus graft is nothing to shy away from. It's a very predictable technique. And when I look at what to incorporate in our practice, it's not so much a difficulty of the technique, it's about the predictability and the manageability in your particular practice. I don't see that right now with zygoma implants, but of course, if you have a surgeon that you're working with, it is a more traumatic technique in my opinion. Can you give an antibiotic pain med schedule for the crestal lift? I can certainly do that. Please email me and I will send you our protocols for doing that. What smart particle bone graft are you using? We're using a product from BioHorizons. It's called Mineros X Cancellus. And that answers two of those questions. Can I use the Versus system in a crestal approach and use ethos as a bone graft? Certainly. I have not used the Versus system with this technique. I'm not sure it would actually be necessary because typically you're putting in a larger implant than the 3.6, and just by creating a smaller osteotomy using the guided kit, I'm not sure you would need the Versa system. Versa has its own system for doing crestal approach. My concern with the Versa system is, are you overheating the bone? We have used similar systems to Versa in the past, using screw spreaders to do these techniques. I just find that this particular guided kit works even better than using those types of systems. I think it's more predictable, but certainly a lot of people are having success with Versa. I just don't happen to use that, but I'm sure you could. Okay. Let's see. How can I put a colored face scan in Blue Sky, and what type of file must be, do you need to do that? That's a question, I think, for Michael. That's not something I've actually gotten into doing as yet, but I know it's possible. I've seen postings on it. So
Yeah,
Mike,
you
Yep.
can import an OBJ PLY. The software supports most of those file formats.
Good. Perfect. And I know that there are a lot more improvements coming in the Blue Sky software. I was just talking to Michael before the webinar about that. So I'm looking forward to the advances as the years go by. It's certainly a lot to keep up with, but they keep pushing the evolution of the software and pushing the technology. And we are all lucky to be benefiting from that. I know it's a lot of work on their part, so I give them a lot of credit for doing that. So again, Michael, I want to thank you for the opportunity today. And I look forward to many more years of working with Blue Sky and taking advantage of your generosity with your software.
Well, Rick, thank you so much for the presentation and for your constant involvement and education, and for the presentation the day after your birthday.
That's fine. It's actually like a little present for me, actually. I enjoy it.
Good to hear. We're very appreciative. Thank you. And I'd like to thank everybody for attending. And we have several upcoming presentations, so take a look at the schedule and go ahead and register for those. Of course, free of charge, 1 CE, and we'll be sending those CE credits within a week or two for today's presentation. So enjoy the rest of your Sunday. Rick, thank you very much, and happy belated birthday.
Thank you again. Take care. Take care, everybody.
Take care.